Greetings. My name is Dr. Marwan Albazoud. I'm the director of the Henry Ford Transplant Institute. I want to thank you for putting your trust in us and the liver transplant team while you're going through your liver transplant evaluation. We also appreciate the family support and the family that's with you today. That's going to be your support as you go through this journey. Our team prides itself in the compassion and the message of hope and the kindness that's built around the program with which we deliver the care to yourself and the support to your family and other supports. Liver transplantation saves lives. In spite of all the innovation we've done and implemented and the ways we've tried to accept organs for those people who are waiting on the list, the demand outstrips the supply. The dire statistic is as follows. Anywhere between 1 in 4 and 1 in 5 people who are evaluated for a liver transplant and placed on the list do not make it to transplant. And the reason for that is nearly half of that number reflects patients who are removed from the list because they got too sick or they died while waiting. And that's very sad when we have the technology and the skills to deliver liver transplantation the way we have now. I would tell you that Henry Ford has invested significantly in developing the Living Donor Liver Transplant Program, which started in 2000. Over 20 years with the same team and excellent outcomes that exceed the averages. So why living donation? When you're thinking of living donation, think about this. If we take 100 people, place them on the waiting list for liver transplant, and another 100 put them on the pathway to living donation, a greater number of people after living donation are alive compared to those who are on the waiting list. And that's because we are not racing against the clock. We can time the transplant. We can do it at a time before you get critically ill. And also, the organ that we choose is highly selected from a healthy person without any complexities. Now, people ask, how do I get a living donor? Our team has put a champion program together, and you can look more information at henryfordlivingdonor.org for more details. But the question is about our living donors. Our living donors, the way we see them, we have an amazing degree of respect because they give such a selfless gift. And we also find them to be a unique set of people, and we call them our angels on earth. We care for them with compassion and truly a fair amount of love and support. And all our living donors that have gone through the living donation for over 20 years, when asked, would you do this again? They had a resounding yes, that they'll be willing to go through living donation again because of the experience that they had gone through, that both made them feel more connected to the recipients and a sense of doing good. Doing good is a big driver among our living donors, and we're so grateful for that selfless gift that they have shared with us. We always say the greatest gift deserves the greatest care, and we care for our living donors in a very unique way. Our living donor team, composed of surgeons and physicians and other healthcare professionals, are devoted to living donation, and they're separate from the recipient team. This is how important we view this.
Hello, my name is Kelly Collins. I am a liver transplant and hepatobiliary surgeon at Henry Ford Hospital in Detroit. Liver transplantation is a procedure in which a diseased liver is removed and replaced with a new liver. Common reasons you may need a liver transplant include liver failure, abnormal pressure in the blood vessels as a result of liver disease, or liver cancer. In 2020, 8,906 liver transplants were performed in the United States. Of these, 192 liver transplants were performed in the state of Michigan. The liver is the largest solid organ in the body. The liver has many functions. It cleans waste, toxins, and drugs from blood, makes proteins, including proteins that help the blood clot, helps digest food, stores sugar and helps the body use sugar, helps use and store vitamins. Cirrhosis of the liver is scarring of the liver that can cause the liver not to function. There is no medical replacement for the functions the liver performs. Liver failure can make people sick in many ways, including feeling tired, feeling cold, being forgetful or confused, or having brain fogginess, losing muscle, thinning of the blood or bleeding from the insides, buildup of fluid in the legs or belly. While there are medications that can help control some of the symptoms of liver failure, there is no medical replacement for the liver functions. A hepatologist is a medical doctor who treats people with liver disease and liver failure. If your doctor thinks that you might need a liver transplant, you'll be sent to our team to undergo an evaluation. A nurse coordinator will be assigned to you to assist with this process. Open communication with your coordinator and the team is important to progressing through the evaluation. The evaluation for liver transplant is extensive, and while this may feel exhausting at times, the goal of the team of specialists is to better understand if liver transplant is the right option for you. The tests and the specialists you meet with will evaluate your medical health, including other problems that you may have that may change the risks of transplant, previous surgeries, or details about how you are built on the inside that may affect your transplant operation, your heart and lung health, your emotional health, your nutrition, and your strength and stamina. Once the majority of your tests and appointments are completed, the team as a whole will discuss how transplant would fit into your life and if it's a suitable option for you. An important part of the liver transplant evaluation is identifying people who can support you in managing your medical needs with liver disease and after transplant. In some situations, it is determined that liver transplant is not a suitable option for someone. If transplant is not an option for you at that time, our medical team will continue to help care for you. The liver transplant waiting list for a deceased donor liver is managed by government contracted agencies named the OPTN and UNOS. Your position on the waiting list is determined by a set of national rules and guidelines. The goal of the waiting list is to give priority to the sickest patients. Living donation is handled separately from this waiting list. The MELD score is a number that is meant to represent how well your liver is working. It is based on your blood work, and it can change over time. The range of the MELD score is 6 to 40, where 6 is the most well and 40 is the most sick. While we often begin to discuss transplantation around a MELD of 14 to 15, the score needs to be higher to be at the top of the waiting list for a deceased donor organ. The transplant community recognizes that there are some problems of liver disease that don't cause the blood work to change and elevate the MELD score. Because of this, in certain situations, a set MELD score may be given to a person on the waiting list who has one of these conditions. These conditions are determined by the national government guidelines. Some examples of conditions that qualify include liver cancer or lung disease as a result of liver disease. Living donor liver transplantation is a situation where the potential liver transplant recipient identifies a person who is willing to donate a piece of their liver. This process is separate from the deceased donor waiting list. However, all potential recipients undergo the same evaluation. If a living donor is identified, a special team is dedicated to the evaluation and care of the living donor. When a donor organ becomes available, one of our 5 liver surgeons reviews the information about the donor and decides if we think that it is a suitable liver for you. Who performs your liver transplant is based on a rotation or call schedule. You will meet your liver surgeon on the day of your operation. If the donor is a good match for you on paper, the team will call you and ask that you come to the hospital in Detroit to prepare for transplant. While you are making your way to us, a team will go to evaluate the liver in person and perform the operation on the donor to get the liver. One of the important things for success in liver transplant is that the liver is outside the body for the shortest period of time. So it is very important that we are ready to start your operation as soon as the team confirms that the liver is usable. However, there is always a chance that when the team evaluates the liver, they will not think that it is suitable for transplant. These false starts can be disappointing, but they are necessary in order to ensure that you are ready to go when the organ is usable. If everything looks okay with the donor liver and you are in acceptable condition for liver transplant, then we make the decision to go ahead with the operation. The liver transplant operation takes about 6 to 8 hours. After putting you to sleep and placing special IVs to monitor and care for you during the operation, the first part of the operation is to remove the entire liver and the gallbladder. Even in situations where you may be receiving a part of a donor liver, your entire liver will be removed. The second part of the operation is putting in the new liver. When we put in the new liver, we make 4 connections between your body and the new liver. The 4 connections we make to the new liver reflect the liver functions. 3 of the new connections, labeled here as 1, 2, and 3, bring blood into the liver and out of the liver and back to your heart. The 4th connection connects the liver to the intestine. This allows for digestive fluid called bile that is made in the liver to flow into the intestine. We generally use 2 types of incisions for surgery. Which incision is used is based on the shape of your belly and ensures that we have enough space to perform the operation. Surgical drains will be placed at the time of your surgery. These drains collect fluid from the belly and help us to assess how things are healing on the inside, based on the color and the amount of fluid. Generally, these can be removed in your hospital room prior to leaving the hospital. After the transplant operation, you will be taken directly to the intensive care unit. In about half of our patients, the breathing tube placed at the beginning of surgery will be removed immediately at the end. In patients where the breathing tube needs to remain in, it is usually able to be removed within the first 12 to 24 hours after surgery. If the breathing tube remains in, you will be given medications to keep you comfortable while it is in place. The ICU stay is typically about 1 to 3 days. When you are stable to leave the intensive care unit, you will be transferred to the transplant unit in the hospital. All of our patients recover in the same unit, and we have an amazing team of nurses and other care providers with experience taking care of post-transplant patients that will assist you with your recovery. The average length of stay in the hospital is 9 days. When you are medically ready to leave the hospital, you will either go straight to home or to a rehab facility. The physical therapy team will help assess where is best for you to go. When you go home, you will need a support person to help you while you recover. We ask that you do not stay alone for about a month. This is not because you will need to be weighted on hand and foot, but you may need assistance with mobility, medications, mood, and transportation. We recommend that you have several people who can support you in this role. If, when you're otherwise medically ready to leave the hospital, you are not quite ready to go home from a strength and stamina standpoint, then you may go to a rehab facility for a period of time before you transition to home. After leaving the hospital, you will be seen frequently in our clinic and have your blood drawn to assess the recovery of your liver and to make sure that you have the right amount of anti-rejection medication in your body. These visits are initially 1 to 2 times a week and are transitioned to less frequent as your recovery stabilizes. Potential complications after liver transplant can generally be grouped into the following categories: problems with the blood vessel connections, the bile duct connection, related to medical conditions or medications. In addition to this, bleeding is a common occurrence in liver transplant. It may occur during the operation or in the first few days following the transplant, and it may require a return to the operating room to fix bleeding or remove blood clots. Liver disease itself makes people at increased risk for bleeding. One of the jobs of the liver is to make protein that helps the blood clot. It can take the new liver a bit of time to get back to normal levels of function. Blood transfusions at the time of transplant and in the few days after transplant are common. You may be at more risk for some complications than others based on your other medical problems or how ill you are at the time of transplant. We will review the other types of complications in more detail. Blood vessels are tubes that carry blood throughout the body. When we make connections between your blood vessels and the blood vessels of the new liver, I like to ask people to think of it like hooking 2 garden hoses together. Our goal is to allow blood to flow easily through the new connection from your body into the new liver and then back into your body. The blood vessels may become narrowed or kinked due to handling, the new connection, or positioning. If we have suspicion that the blood vessels are narrowed or kinked based on tests, we have several ways we approach this. Sometimes we use blood thinners to keep the blood from getting clogged in the narrowed area. Sometimes we place a straw or stent through the narrowing in order to prop it open and allow flow. On rare occasions, we have to return to the operating room to redo this connection. What we want to avoid or prevent from happening is blood cells getting stuck in the narrowing and leading to clogging or clotting of the blood vessel. If the blood vessel becomes completely clogged or clotted, it can cause the liver not to function. This happens infrequently, but may require that we perform a new transplant. Early retransplantation occurs infrequently, less than 5% of the time. Reasons for early retransplant include blood vessel complications and also a situation termed primary nonfunction. Primary nonfunction is a situation where, in spite of the liver looking acceptable on paper and in person, and the operation being fine, the liver does not function appropriately for reasons that we do not completely understand. In these situations, we do a new transplant as soon as possible. You may get a special status on the waiting list, placing you at the top of the waiting list. The bile duct is a tube that carries digestive fluid from the liver to the intestine. Complications with the duct include leaking or narrowing of the connection. If we have suspicion that there is a narrowing of this connection, we do a procedure called an ERCP. This procedure is similar to an EGD, where we use a video camera to look into your stomach. However, in an ERCP, we look further into the area of the intestine which is connected to the liver. In an ERCP, the video camera views into the intestine and we look for any narrowing in the connection to the liver. If there is narrowing, temporary straws or tubes, like these blue tubes shown here, are placed into the duct to stretch the connection. In 6 to 8 weeks, the procedure is repeated. If the narrowing persists, the stents are replaced. If the narrowing has resolved, the stents are removed. In rare situations, we have to return to the operating room to fix an area of narrowing. After liver transplantation, you will take medications to prevent rejection for the rest of your life. These medications help protect your body from attacking the new liver and causing damage to it. The same cells that are weakened in order to protect the new liver are the cells that help protect our bodies from infection and guard against abnormal appearing cells. Because of this, these medications increase your risk of infection and cancer. The most common cancer following liver transplant is skin cancer, so it is important that you use sun protection after transplant and that you see a skin doctor once a year. There are some lifestyle changes that go along with transplant that are largely targeted at decreasing your exposure to infections. You will learn more about these during the evaluation process. Survival following transplant is very good, with the 1-year post-transplant survival being greater than 90%. Issues during the first year are largely related to the complications of surgery previously discussed, as well as infection. The 5-year post-transplant survival is 75 to 85% and may be affected by medical problems you have unrelated to transplant. I always tell people that if organs grew on trees, they would all look alike and have the same story. However, this is not the case. Every organ has a story and risks associated with it. A large part of our job is to assess organs and decide which risks are acceptable. Any liver we offer to you, we feel is safe to use. I'm going to explain some of the characteristics of donors so that you'll have familiarity with the terms when you are called when an organ becomes available. A donor who is brain dead has been evaluated by a medical team and found to meet established criteria for brain death. The way organs are recovered in this process allows the heart to remain beating and providing blood flow to the organs up until the moment of organ removal. This is in contrast to a heart death or DCD donor. In DCD donation, the decision has been made to withdraw life support on a donor and allow the heart to stop. When the life support is withdrawn, if the heart stops within a certain time frame, then we are able to utilize the organs for donation. Because of the way this process occurs, there is a period of time in which there is no blood flow to the organs. This increases the stress on the organs during the transition from donor to recipient. While the overall outcomes for brain dead and DCD donor livers are similar, this added stress during the transition period may result in a longer healing period and has an increased risk of scarring of the bile ducts. Split or partial liver transplant occurs in two situations. In living liver donation, about half of a donor liver is removed from the living donor and placed into you. This healthy piece of liver is large enough to meet your needs and will continue to regenerate over time. A second situation in which a piece of liver is used is in deceased donation. In deceased donation, if the first person on the waiting list does not need the entire liver, for example, if it is a small child, the remainder of the liver is offered to the next person on the waiting list. Regardless, if you receive a whole organ or a piece of an organ, your entire liver and gallbladder will be removed. All of our donors are tested extensively for infections. All of the donors test negative for hepatitis and HIV. These tests are very good, but they are not perfect, and so there is a very low risk of unintended infection. If there is concern regarding donor infection risk, this will be discussed with you. Because of this low risk of unintended infection with all donors, all liver transplant recipients are routinely tested for these viruses in the post-transplant period. Hepatitis B core antibody positive donors. This is a situation where the donor's blood work suggests a prior exposure or infection with hepatitis B, but they have no sign of active infection. If you receive this type of liver, you will need to take an extra pill along with your other post-transplant medications in order to prevent reactivation of the virus. Hepatitis C positive donors. In recent years, the medications to treat and cure hepatitis C have been revolutionized to a point that we are now able to transplant livers from donors with hepatitis C into people without hepatitis C. In this situation, the donor's blood work shows hepatitis C, but the liver does not show any sign of damage from the virus. Following transplant, you will be treated for hepatitis C. We typically begin this treatment within the first month after transplant. The treatment course lasts about 12 to 18 weeks and has a 96% cure rate after this single course of treatment.
So I hope that as you go through the journey of your liver transplant evaluation, you know that the entire liver transplant team is behind you, whether you go for a deceased donor on the waiting list or opt for living donation. And we are there to support our living donors as well. Knowing what you know today and what we've shared on this video, if yourself, your family member, or an interested party would like to get more information on living donation, I would urge you to go to henryford.com/living donation. On this website, you will find information on how to pursue living donation or questions and answers and frequently asked questions, and a link to our coordinators and our team as well. I wish you the best of luck on your journey.